It's a very popular area, as I can see by all of you. I was actually talking with your gynecology professor, and she was saying that for this research paper, people have to do a research write-up, and like almost 25% of the students are choosing infertility aspects of gynecology, so I know it's a strong interest of the student body, and I think it's a really important area to be doing work as a naturopathic physician, because it incorporates so much in preventive medicine. It incorporates every tool you're going to use in school, from counseling, like working with a couple that's really struggling with something, which often has financial stressors, relationship stressors, etc. Being able to work with people through that. Working on nutrition, looking at environmental medicine, and the impact that their own environment has on their health and their ability to conceive. And then you think about the impact that you can have on the next generation from a preventive perspective. You know, one of the things that I loved researching, I did a presentation at the AANP a couple years ago on this, was the fact that the behaviors that mom and dad have for the 3 or 4 months before they get pregnant, and then the behaviors of the mom when she's pregnant, it actually lays an epigenetic imprint on the genome of the baby. And it has a higher level of impact on that child's health outcomes, like obesity and type 2 diabetes, than their own lifestyle choices do, from birth through, you know, age 50. So it has a huge impact. So I think when people understand that they have the ability to make choices that could have that kind of positive effect on their baby, it's really empowering. And the other piece of it from a practice perspective is that your patients are so engaged and so ready to make change. You know, they'll oftentimes do more when they're trying to conceive than they would do to manage their own illness, because they so want to have a baby that they'll take the supplements, they'll make the lifestyle changes, they'll take on the exercise, and they'll do the hard things that they might have struggled to actually implement. So it's a group that's really excited to work with you. So it's just a lot of fun all the way around. So I'm going to give you guys kind of a primer on finding and treating the cause of infertility, just to get an idea of who's here. Who is in their last year of school? Nobody. Everyone's at the clinic who's in their last year. Who has 2 more years left?
No.
All right, who's in their second year? 3 more years left.
Same thing.
What's that?
Some people are in 5.
All right, so who is in 2 or 3 of 5? Who's in their first year? Awesome, what a good mix.
We're nutrition students.
Oh, well, you can't stay. I'm just kidding, of course.
We're in our first year.
Great. Well, I'm going to cover some of the basics, and since a lot of you are not yet in the clinical years, I'm not going to dive too much into specific clinical modalities, because this will lay a really good foundation where you'll get a lot out of it. And then when you get into the more advanced classes, you'll even add to the layers of information about this. Is anyone in urology right now? Nobody? Okay. Because I'm teaching there later, and you're going to get hard. They're going to get it hardcore. So, over 6 million people in the U.S. have impaired fertility. That's 2.1 million married couples. And just to put that in perspective, that's an incidence of about 1 in 8 couples. That incidence is the same as breast cancer. Right? Do we talk about infertility as much as we talk about breast cancer in our culture? Definitely not. It's something that a lot of people suffer through silently. You know, they may never share with family members outside of their partner that they're having trouble conceiving. And there's unfortunately still a lot of, I would say, shame and embarrassment over that fact. But it's a group that really needs a lot of support. So to be able to build a trusted relationship with a practitioner who can help them through is really a gift, because it's a huge, huge problem. And it also makes us think about our world in general. What is leading us to the fact that 1 in 8 couples can't have a baby on their own, needing IVF and things like that? Something's wrong. There's a piece that's missing, whether it's environmental factors or poor nutrition, and probably a combination of all these things that we need to address as a larger society, because it's starting to have a big impact. So about 10 million couples have sought treatment for infertility. And interestingly enough, 30 to 40% of the time it's a male factor. About the same incidence, it's a female factor, and about 20 to 30% of the time it's a combination of both, where both partners have something going on. I see that a lot. I would say it's what I would call subfertility. No one is infertile, but the male's semen parameters are just not that great, and maybe the female has a little bit of hormone imbalance and things just aren't coming together. So we define infertility for people under So for people under the age of 35, they should be able to get pregnant in 6 months or less. If it takes longer than this is backwards. So for a woman under the age of 35, they should be able to get pregnant in a year. Okay? If they're not, it's considered infertility and it warrants being evaluated. If you're over the age of 35, they do an evaluation sooner, so after 6 months. And the reason for that is there's a higher likelihood of, for example, eggs not being as good a quality because of the woman's age. And in the US, most people go into kind of conventional treatment options first. This would be what their gynecologist might recommend. And then if that doesn't work, they'll be sent on to what's called a reproductive endocrinologist. And they're the ones who specialize in things like IVF. So there's a couple things. These are the kind of order people typically go through. The first would be what they call fertility drugs. I'd say sometimes people get pregnant on them, but they can also have kind of an anti-fertility effect, unfortunately, in the long term. So the biggest one used is called Clomid. People heard of Clomid before? So this is one where you take drugs orally. The other one that's commonly used is called letrozole, and they work very similarly. Basically, they block the hormone estrogen from being really signaled and sensed in the body. So your ovaries make estrogen, but the brain doesn't sense that it's there. So the brain sends more of a hormone back to the ovaries saying, make more estrogen. So it causes your body to make more what's called follicle stimulating hormone, or FSH. We're learning about that in physiology. So your body naturally makes more FSH, it makes more follicles, and it basically blocks the negative feedback that estrogen would normally have to the brain. So it causes you to pump out more FSH and mature more follicles. So this is why on Clomid, women can ovulate with multiple eggs rather than just one. Higher incidence of having multiple births. So typically if a couple was having trouble conceiving, even before they would be worked up by their gynecologist, they would usually say, well, let's put you on 50 milligrams or 100 milligrams of Clomid. Do that for a couple cycles. You guys have a new baby.
Yeah.
Oh, beautiful. That's what happens when things go right. And they'll have them try a couple cycles using Clomid or letrozole, and then if they don't get pregnant with that, then they'll work them up farther. Okay. So next what they'll often try is called artificial insemination. Now we call it IUI, or intrauterine insemination. And this is what they do is collect a semen sample, they wash it, which removes basically everything in the semen except for sperm. And then it gets kind of concentrated in a smaller amount. And the woman is usually on Clomid or letrozole with this. And then they insert the semen into the fallopian tube or into the uterus, depending on the procedure, allowing it really just to get closer. It basically gets sperm closer to the egg that's being ovulated. And IUI does have a lot of documentation that it can be helpful when there is an issue with like sperm motility, for example. If the sperm can't swim as strong, it just shortens the distance. So rather than a marathon, they only have to go a mile, right? So more survive, more get to the egg, fertilization can occur on its own. If that doesn't work, the next thing is what we call ART, or assisted reproductive technology. And this is where we get into in vitro fertilization, or IVF. And IVF, sometimes they'll add this thing called ICSI. So IVF, basically what that means is the woman takes a much stronger course of medication, usually injected, not oral. And that will stimulate a lot of eggs to be developed. She needs to be closely monitored through the process, so she'll have usually ultrasound almost every day or every 2 days, depending on the doctor. And then when they determine she's ready, they give her a shot of HCG, which is the thing that you sense when you're pregnant. But that stimulates ovulation. And then they go in with basically a surgery. She's under anesthesia. And they go in with a needle and aspirate the eggs out as they're ovulating, coming out of the ovary. And then they collect a semen sample. Men have the easiest part of that job compared to a woman with IVF. And then they take the egg, usually a couple, and they'll mix them with the sperm in a petri dish and allow them to fertilize. And they watch them under microscope over the next couple days. And then the ones that fertilize, they take those embryos and then they implant them back into the uterus. So it's a second procedure for the woman. This time she doesn't need to be put under anesthesia. It's done through like a little catheter right through the cervical os. So it's about as invasive as having a pap smear, right? It's not that bad. And then they go back in and implant and put it into the uterus where it can implant. Okay. ICSI is done, which stands for intracytoplasmic sperm injection, which sounds like something you might see in a sci-fi movie. But what they do there is when the sperm and egg are put together in a petri dish, if the sperm can't fertilize the egg on its own, they actually use a needle and pull some sperm, usually one, up into this needle, poke through the wall of the egg and inject the sperm into it. Okay? So it's basically artificial fertilization. Now you can imagine there might be problems with this, right? This is really bypassing every protective step that Mother Nature has, and there are some, although it's debated, there are some genetic and epigenetic diseases that are seen in babies born to ICSI that don't exist in the general population. And it's likely, I mean, if a sperm doesn't have what it needs to get through an egg wall, does it have what it needs to make perfectly functioning kidneys and liver and heart tissue and, you know, the rest of the human body? So there are definitely some concerns with that. But it's used in up to 60% of IVF attempts nowadays, but becoming very popular. And then GIFT and ZIFT are very uncommon, but basically what they do is extract the egg and sperm, but then inject them both back together, in this case, into the fallopian tube. So there's just a couple other options available. We won't go through those in detail because they're not used very frequently. So, you know, in my opinion, there's a huge just paradigm difference in how naturopaths address fertility and how conventional medicine addresses fertility. In that conventional medicine, I would say, overcomes infertility by using procedures that are more invasive and doesn't require the body to do what it needs to do to get pregnant on its own. Right? Naturopathic medicine looks to treat the underlying cause so that people can get pregnant on their own. So another piece of it is with conventional medicine, their outcome is, are you pregnant? Do you have a live baby at the end of pregnancy? Where I think as naturopaths, we care a lot more about having a healthy baby, right? I always tell parents, you're making, your egg and sperm are the blueprints to build this house, right? To build this child. So you have to make them, each of you, as healthy as possible, because when they come together and make the genome of your baby, that's the best health outcome that baby's gonna have. You know, you kind of set the bar there. You build the blueprints. So it is really important to do the work to prep those blueprints. So that's what we call preconception care. And this is something that if you're gonna be in clinical practice, you should be talking about this with every woman of childbearing age. Women especially, men it's important too, but for women especially, making sure that they have the nutrition they need in order to support a healthy pregnancy if they were to fall pregnant. This is why March of Dimes worked so hard to get folic acid into our food supply, supplemented, because women would get pregnant without knowing it, and their babies would be born with what? Neurotube defects or like spina bifida, right? So they want to make sure that supplementation of folic acid into your Cheerios is as part of preconception care, right, for the general population. But there's a lot more that is necessary to have a healthy baby and healthy pregnancy. So sperm and egg development take about 4 months. So that 4-month period before you conceive is this really great time to work on getting healthy and helping couples be as healthy as possible. So when they conceive, their egg and their sperm are going to be in the best shape possible. I see this bear out in my practice too. Most of the time when I start working with a couple, they'll get pregnant between months 4 and 6. And I usually will let them know that ahead of time. You know, this is not a quick fix. When you go in for IVF, you could walk into your first doctor's appointment. Depending on where you're at in your cycle, they might run blood work, get you on meds in 2 or 3 days, and be doing a, retrieval of your eggs within 2 weeks' time, right? They might get you pregnant that very first cycle. With naturopathic medicine, I have to set the intention that this is going to take a couple months. You know, you have to actually work to get things better. And if you have 25% improvement month 1, 50% month 2, you're not going to be at that full treatment until you hit 4 months time. And I actually see that with my patient results, that typically people don't get pregnant before the 3rd month. So our clinic uses, kind of the program we built was based upon research done by a group called Foresight, which is out of England. And they are an organization that promotes preconception care. Okay, so their thought is that by maximizing the health of the parents, you maximize the health of egg and sperm, And then you increase the chance of having a healthy conception, a healthy pregnancy, and a healthy baby. So they have one study that was done. This is actually currently being repeated in University of Maine Medical Center. But this is an older study, maybe 5 or 6 years old, published in 1995, so I guess a little older than that, where they looked at 367 couples in England. Women were between age 22 and 45, men between 25 and 59. And you can see the group of couples, about 37% had a history of infertility, 38% miscarriage, therapeutic abortion where there was something wrong with the pregnancy and they had to terminate, stillbirth babies, babies that were low birth weight, or had malformation or SIDS. And what they did was very simple. They gave like whole foods nutrition and they put them on a prenatal vitamin. That was about it. No fish oil, nothing fancy. But what they saw was that within 2 years, 89% of the couples enrolled had a live birth. 81% of those who had been diagnosed with infertility got pregnant on their own and had a healthy baby. And then the health of the babies were great. So the average gestational age was 38.5 weeks. So pretty much full term, right? 40 weeks is what we consider full term. The earliest was 36 weeks, so that's a little bit on the young side, but nothing terrible. Compared to the general population, that's a big improvement. And the average birth weight was very healthy, right? There weren't a lot of babies that were born with low birth weight. There were no miscarriages, no perinatal deaths, no malformations. And if you look just statistically at 389 births in England, you should have expected 70 miscarriages and 6 malformations. They had none picked up in the study. Okay, no babies admitted into the NICU. So really great outcomes there with very simple interventions. But like I said, it was not really a naturopathically designed program. It was really very basic, more of a nutrition, a nutrition protocol. And so I think when we add to that diet, lifestyle, and then kind of couples counseling, you really can offer even more. So when I work with couples, I think it's really important to consider a lot of different pieces. The first is, what's their toxic load? I think this is more and more important. I gave a talk last year about basically the environment in fertility. And the research is pretty amazing on the effects of PCBs and bisphenols like BPA and plastics, a lot of the agricultural chemicals. I mean, I really think plastics especially, like bisphenols and phthalates and stuff like that, they are really wreaking havoc on our fertility. And actually, you know how they determined BPA might not be a good thing to give to babies? Because near this factory where they were utilizing it, this is about 15 years ago, the stream nearby the factory, all the fish became hermaphroditic. So they started to see that male fish were becoming female and female fish were starting to develop male partners. And they said, I wonder if this is safe for humans. Right? This is after it's like ubiquitously used in our world. So now you'll see all these BPA-free plastics, right? But the problem is that what they're using is typically a substitute called BPS, bisphenol S. It's a related compound. You guys are nodding, but you already know this. On the East Coast, it's new information, but out here you're probably all aware. That's even worse than BPA from early studies. So there's very few studies. I've only seen 2 human studies published, but it appears that the effects on fertility of BPS are actually worse than that of BPA. So I think the bottom line here is like stick with stainless steel or glass, things that have been around for a while that we know are inert. And I think getting people off of plastics in their food supply is a really important piece of working with infertility. I also encourage people to go organic as much as they can afford, especially starting with dairy and eggs, and then going on to animal products, and then fruits and vegetables last. You want to start at the top of the food chain because those are most highly contaminated. And unfortunately, most animal products, the animals are fed hormones, right, in order to produce more milk, make more eggs, or grow faster. So I think that there's a higher risk of hormonal disruption there too. Because that kind of brings us to hormonal imbalance. That's certainly something that you want to address. For, I would say, women more than men. Men are a little bit easier to evaluate with infertility because you can take a semen sample, which are pretty easy to acquire, and you treat based on what comes back, and then you can do a follow-up test to see what's changed. Women are a lot trickier. There's a lot more pieces to it for a woman, you know, where you have to have, the cycle has to be regulated, you know, the placenta has to develop properly in order to keep the pregnancy. Bless you. So there's a lot more to it for a woman. So definitely getting the knowledge of her hormone imbalance support. Body weight is a huge piece. You know, obesity is a big problem. Seattle itself is kind of a little bubble where we don't see as much obesity, but most of the rest of the country, it's a big problem. And being too high or too low in body weight significantly affects fertility. Stress level, kind of preaching to the choir here, right? All of us are living that life where our cortisol levels and our stress levels are higher than they probably should be. But this also can have a big impact. It can directly impact hormones. When you make more of the hormone cortisol, does anyone know what cortisol is made from? Cholesterol. And in between those two, a hormone called pregnenolone. And pregnenolone is also the backbone to what other hormone? Progesterone, right? So when stress goes very high, the pregnenolone can be pulled to make more cortisol, which is more of an urgently needed hormone. And then progesterone can be left a little bit deficient. So a lot of women end up when they're under a lot of stress will be low in progesterone, and even the name progesterone, right? So pro meaning in support of, and gesterone, what does that sound a lot like? Gestation. Gestation, right? It's our progestation hormone. It's a pro-pregnancy hormone. So if you can't make enough of that, you're going to be in trouble, right? So stress actually biochemically affects that. We know it has other pathways that it affects that. Even when we supplement progesterone, it can still be hard to get pregnant. So there's more to the picture we don't understand. But it's definitely important. And then the emotional considerations of helping a couple that's going through this process and struggling. So in our office, couples go through at least 4 months, like I said, because it takes about 100 days to make an egg or make sperm. And we will do a complete health history, lab testing, and screening. We'll have couples chart their cycles, which we'll talk a little bit about today. I don't do a ton of this lunar biorhythmic cycle, but one of the clinics I studied in Australia worked heavily with that. And I have seen couples get pregnant with their moon cycle versus their menstrual cycle, which the idea behind that is that every month, you know, the moon changes phases constantly. And when it returns to the phase that it was in when you were born, for women, they have a higher rate of spontaneous pregnancy. So when I was in Australia, they actually worked to shift women's menstrual cycles so that their ovulation would align with the return of that phase of the moon. But I've also seen women get pregnant when they have their period, and that lines up to the lunar phase. So I mean, I've seen some kind of weird things that say, well, if the moon can move the oceans, I guess I won't rule out that it could impact our ability to get pregnant. And then a lot of lifestyle counseling too. So for health history, I always want to know, tell me your story of why you're here, how you got here. How long have you been trying? What have you tried? Have you gotten pregnant and miscarried, or have you just never been able to conceive? I'll want to know about their family medical history. Definitely for a woman of menstrual disorders and breast and ovarian cancer and infertility and miscarriage, but also other things. I had one patient that came in that had a really heavy mental illness in her family history, and she herself had struggled with anxiety and infertility, and through that family history it led me to say, well, let's screen you for the MTHFR defect, which is a defect on processing folic acid, and it really has a big impact on mental health as well. And she came back positive, and when she got on the right form of folic acid, she got pregnant right away. So sometimes looking beyond just their fertility family history can give you some insight into what else might be going on. Their own personal history and current health status. Do they have hypothyroidism, which can impact fertility? Are they dealing with an autoimmune disease? Is their body kind of in this state of inflammation? You want to know all that stuff because that will direct your treatment. Or digestion. That absolutely could impact their fertility by making it tougher for them to absorb nutrients. You review any recent labs, and I'll do a full physical exam, including a pelvic exam for a woman the first time that they're coming in. If there's a male fertility issue, I'll also do a male physical exam, obviously looking for things like varicose veins and stuff like that. And then after you figure out what might be the obstacle, you want to, work with supplements and herbs to treat my patients. So we'll get into some of my favorites there. So with menstrual cycles, I'll teach the woman to chart her cycles. There's two things that I primarily use. Who's familiar with this already? Okay, good. So some people that aren't, so I will spend some time going through it a little bit. Essentially, you know, you can, and I encourage every woman to do this just to learn about your body. I think it's a very amazing thing that every woman should know. I was telling Sarah over lunch, we should teach it in 5th grade. It should be like part of sex ed. So basically, throughout the course of your menstrual cycle, there's some changes that occur to your body that are pretty easy to detect. One is that the mucus or the fluid that's made by your cervix changes pretty dramatically from none to like maybe like sticky or milky or watery discharge. Around the time of ovulation, you'll get way more discharge and it will look like egg whites, this like thick, stretchy mucus. And that's a sign that your body is fertile, okay? You make that mucus in response to estrogen being produced. And what it is, it acts like a sperm superhighway, okay? So typically cervical mucus, if you looked at it under a microscope, the fibers and the will kind of be in this crisscross fashion, and it acts like a block to prevent semen from getting through the cervix. And what that does is it makes it so that you have a lower risk of catching a sexually transmitted infection, right? If a man's semen had, you know, gonorrhea or something in it, that is a natural protection to prevent semen from getting into your uterus where it could cause an infection. Okay? But then around the time where you're fertile, if you looked at it under a microscope, it all goes up and down. And it actually creates these slippery channels that sperm can swim through to actually make it easier for them to get up through the cervix into the uterus. I think it's pretty amazing. Yeah. And not only that, but it also contains food for the sperm. So it's higher in glucose and higher in certain nutrients like zinc that sperm need in order to survive. So you actually, like a woman's cervical fluid, makes basically a slip and slide that feeds you to get them right to where they need to be to fertilize an egg. So it's a very cool transition that happens, right? And then it will go away. So it typically lasts about a week. So it's nice for women to be able to detect that. And I was, you know, telling Sarah that I have women that'll be like 45 or 50 that will come in my office and say, yeah, like my whole life I've been getting like a little bit of a yeast infection, like right around the time that I ovulate. And it's like, that's not a yeast infection, that's your body doing its job, right? So I think it's really important for women to know that that's normal, that that variation in fluid is normal, and kind of what to know and what to expect. The second piece is that you can take your temperature orally. You want to do it first thing when you wake up in the morning, before you get out of bed or move around. And what happens is your temperature will, you know, be pretty stable the first half of the cycle, and then after you ovulate, that's when you start to make the hormone progesterone. And one of the effects of progesterone is it actually raises your body temperature. So once you ovulate, your temp will go up. It's just a couple tenths of a degree, but you can detect it, that you'll have the shift where the first half of your cycle is a little lower, the second half is a little higher. So what that does is it can confirm, yes, you've ovulated. So I have women chart their cycles like that, and ideally my goal is they'll take their temperature for like 3 months, couple months, 2-3 months, until they are able to feel confident that when they see their mucus change, that yep, then the temperature shifts and I know I ovulated. So it's just confirming what they think they saw with their cervical fluid, right? So you can kind of teach people to know when they're fertile. This is especially important if you have a woman without normal cycles, right? If a woman has cycles where sometimes she's every 28 days, it could be as much as 35, 36 days, they don't even know when to try. It could be a timing issue. This can definitely fill her in.
I was just curious, with people who don't have a perfect like night's sleep, or who get up and pee every morning at like 4 in the morning, is it still worthwhile doing the temperature? Do you still see accuracy and kind of like they get up at different times in the morning and everything? Is it still worth doing?
Yeah, so it depends on the person. Did you guys hear a question in the back? So it depends on the person. Some people are so sensitive that it will not really be a great chart if they're not waking up at the same time, or you know, if you have a cold and your temperature shifts because your immune system's active, it's going to throw things off. For me, I travel across time zones, so I mess that whole thing up. You know, but if you can get on a regular schedule, that's definitely better. So I would think it's still worth trying for a couple cycles, see what the charts look like, and then take it from there. Yeah. So this is just a couple examples. I won't spend a ton of time on. These are actual patient examples of mine. So of couples that are trying to conceive. So you can see they mark like when they have intercourse and stuff like that. You know, when they have their period, what their cervical fluid looks like. So when I look at these charts, I want to see, you know, first thing I look at is, did they have a temperature shift? So did they ovulate? In this case, yes. You can see it's never perfect, it's never like a straight line, but you can see there's like these lower temps and then there's this high shift and then the temps stay pretty high. That's a good sign that ovulation occurred, and usually it's like 2 or 3 days before that shift happened. Okay, because you have to wait for progesterone to be made. Right? So this thumbprint is where the computer software thinks they ovulated. You know, the 16th or 17th day of their cycle. Then the next question is, does their cervical fluid line up with that? In this case, it does. You can see that she was making more and more fluid. She felt like she had the most fertile mucus here, and then it started to taper off. Okay? So those are really the 2 key things to look at.
What program is this?
This is, it's called TCOYF. Taking Charge of Your Fertility. They have like an online charting software, which is another great book. It's in the resources section of this.
It's also in the bookstore.
Great, yeah, by Toni Weschler. It's a book this thick that tells you how to do this. And I think it's a little bit overwhelming and confusing. Has anyone read it? Yeah, it's like all these, like the phase 3 shift rule and the, this rule and that rule, and you can be like, I don't get it. I don't think you need to read a 300-page book to understand this. But if you really wanted to get into it, or if you want to use basal body temp charts in your practice to understand a cycle, I would definitely read the book because you'll get a lot of insight into kind of how to interpret weird cycles. So what do you think is going on in this cycle? Does she have a temperature shift? No. No. Does she have like a good shift in her mucus? No. She thinks she's having fertile mucus like all month long, right? No real change here. So this is a woman who didn't ovulate in this particular cycle. So some of the things that can lead to this are like PCOS, polycystic ovarian syndrome is one example. In this case, she just ended up having a very, very long cycle. What about this one?
Yeah.
Temperature shift?
Yeah.
Yep. Mucus, you can see the cervical fluid kind of went up and down, but she did get some good cervical fluid around the time of her ovulation. And in this case, she actually got a positive pregnancy test. This is a patient that, what you'll see is as you're near the end of the chart, end of the cycle, go back here. You can see that towards the end of the cycle, so progesterone is made by the corpus luteum, which is like, I think of it like your eggshell, basically, that stays in your ovary. It makes progesterone for 14 days, like a timed bomb, and then it stops. It just poops out unless you get pregnant. So what happens is you makes progesterone, and then it starts to kind of get tired and trail off, and then the progesterone declines, and that triggers a period. So if you have a patient that's getting pregnant, what they'll see is they'll be calling you, towards the end of their cycle saying, my temperature's not going down, I could be pregnant, which is what happened here. So this is, I mentioned already the lunar biorhythmic cycle, but it does seem like the moon's ebb and flow can kind of influence fertility. Oh, did I pull out the chart here? So basically, you can look online to see what phase the moon was in on the day and time and place that you were born. And then you can look up at lunar charts online and see like what day of the month that returns, that phase returns, is the idea behind it. And they actually have thought that this might explain some, there have been times where fraternal twins will be born, where there's 2 different eggs and 2 different sperm, but they actually developmentally seem like they're a week apart. They've thought, could they actually be a week apart, right? Is that a possibility, that you had a regular ovulation and like a lunar ovulation? So this is one case of a patient that's like, it was one of those, I don't really know how I got pregnant. And they brought this chart into me. You can see they had, a normal temperature shift. It, looks like they ovulated around day 12, but they didn't have sex anywhere near that time. Okay, they only had intercourse on days 4 and 5, and then, like day 23 of her cycle, and then she got a positive pregnancy test like 2 days later. Right, so this is a case where we know it's unlikely she got pregnant here because implantation couldn't have occurred, but it's likely she got pregnant on one of these 2 days where it was not even close to her ovulation. And then when we ended up looking up her lunar peak, just out of curiosity, it fell on this day. So this is a case where it's like, well, it's not a scientifically studied process, but there have been enough of these that I'm like, there might be something to that. That's very interesting.
Question?
Yeah?
Do you have resources that we can look at to read more about that?
Yeah, there's a great book called Natural Fertility by Francesca Nesh, who is a naturopath in Australia. It's hard to find because it was never printed in the US. But she goes into that, and actually, I think she wrote a whole separate book on lunar pregnancies too. I have not read that one. She has a chapter in her natural fertility book though.
Can you repeat that?
Yeah, Francesca Naish, Naish.
So not to sound skeptical or anything, but is it possible for the sperm to survive for that time, for on the 6th day all the way till ovulation?
It's possible, but it's highly unlikely.
Highly
So
unlikely.
sperm, typically about 90% will die within 2 days. They have been known to last up to 5.
Infertile cervical fluid.
Right, in a
Which
fertile,
she-
yeah, she didn't have fertile cervical mucus either. So it's definitely possible, it's just, those would have been some awesome sperm. I hope he donates. So we don't have a ton of time on, we're taking a lot of time going through, but, you can probably guess the diet, organic whole foods like we've talked about, not having alcohol, cigarettes, caffeine, things that are known teratogens, meaning they damage DNA. Also really important, there's a lot of studies on glycemic index in fertility, so you want to make sure patients are eating a low sugar, low glycemic index diet. There's actually been a mounting amount of evidence on the Mediterranean diet for fertility, and that's a diet we promote in our practice. It's like a low glycemic Mediterranean diet. Mediterranean diet is primarily plant-based. The animal proteins are almost exclusively fish and some poultry. Lots of beans, healthy fats, obviously no trans fats, stuff like that. So that's really what we promote there. I think having purified, filtered water is very important. There are a lot of crap in our water supply now, including, there was actually a New York Times article where they looked at like 7 key cities in the US, and they measured like in each water supply up to 200 different medications. And guess what's one of the most commonly used classes of medications? Oral contraceptives, right? And they were able to detect them in every major water supply. So, are they enough that we could use them as birth control? Obviously not, but is it enough that a sensitive individual could be affected? Definitely, definitely. We look at their chemical exposures. I actually have a couple that, I do a lot of phone work. This is a couple that's on the other side of the country that I spoke with this last week, that they had a first pregnancy, no trouble getting pregnant, they got pregnant on their first try, and then they're struggling to get pregnant now. They've done IVF, it's failed. They always will get fertilization to occur, but they don't survive, they're not good quality. And they, interestingly, they're 32 years old, both the male and the woman have major sperm and egg quality issues, which occurs with aging. I see a lot of egg quality issues, but usually it's because women are, between 35 and 45 trying to get pregnant. And it's really rare that a woman in her low 30s will have problems with egg quality. So I'm actually looking right now, we're doing a lot of testing for heavy metal exposure, things like that, because I suspect they relocated to Massachusetts. I mean, when they moved to their new house, now they can't get pregnant. So the question is there something in their new environment that wasn't in their old environment that might be hindering both of their fertility? Because neither of them had a problem before. So, you can kind of get hints like that through your questioning. So nutrient supplementation, I do put people on a lot of supplements. I don't think it's a ton, but they're usually on like 5 or 6 things. This is, obviously a huge list because it breaks down every nutrient that's really important, but everybody will be on a really good multivitamin, a prenatal vitamin, or the man would be on a great multi as well. You want to look at things that have enough B vitamins, especially B12 and B6. Definitely folic acid. If you could find one with the methylfolate, that's even better.
Do you have one that you recommend that has the methylfolate?
Yeah, there's a couple that I like. So Pure Encapsulations makes one called Prenatal Nutrients that doesn't have the methylfolate, but it's really great. Thorns does have methylfolate, so I like that one too. And for a man, there's a great one called One Multivitamin. It's like O.N.E. It's like hard to find and search for because of that. But it's a one a day that's actually really nicely built and put together. It's not like comprehensive. It doesn't have calcium and magnesium and all those bulky minerals, but it has methylfolate, extra zinc, extra chromium, has either 1,000 or 2,000 units of vitamin D in one. So it's just very well thought out, I think. So I'll have a man take 2 a day. Has CoQ10 in it, which is a great male fertility nutrient. So it's a really well-designed one. Question?
Well, I was just wondering, like, if you're testing for the MTHFR gene, are you testing for, like, the COMT?
I don't routinely test for a lot of the genetic changes anymore, especially MTHFR. I just put people on the methylfolate because there's no risk of harm. It's gonna work for everybody. And in our area, it costs about $500 to run that screening test. So, I mean, that would pay for all their supplements for like their whole treatment protocol, right? Even if it bills through their insurance, it's costing them money in the end, right? So I'd try fully.
But if you're on one of these prenatal, or the multivitamins that are already methylated, or most of the vitamins are in their methylated forms, do you need to be on, like, if you did have an issue, would you need to also be on a, more, or on one
You
of
might.
the supplements you're talking about?
Yep, you might. So yeah, you might decide to put them on extra folic acid. So a multivitamin will usually only have, I mean, a prenatal, like a technical prenatal, will usually only have 800 mics still. Because prenatals are just more tightly regulated. Like in order to be a prenatal, you know, the parameters of how much of each nutrient are very slim, like iron and folic acid and stuff like that. So you might decide to put them on additional. That woman that had the detected defect, I had her OBGYN, after we picked it up, said, I want you taking 10 milligrams of folic acid daily. Instead, we put her on 2 milligrams of methylfolate. So yeah, you can definitely change the dose there. For a woman, I think CalMag is also important with vitamin D3. So the CalMag is really to replete her. You know, I always tell moms, the baby will get what they need. If you can't take your multi because you feel so sick in the first trimester, the baby will plunder and steal and get anything it needs from your body. You'll just be deficient after you have the baby. So these nutrients are for you. Fish oil, I do usually 2 to 3 grams per day of EPA plus DHA. I might put them on a detoxifying formula to start with. Higher dose vitamin C, probiotic. Selenium is a great antioxidant, and zinc is really one of the ones that we consider one of the most important nutrients for fertility, and it's very commonly deficient. So zinc can be disrupted by the copper T IUD, if anyone's had that. I use the Paragard, or also birth control pills can deplete zinc. So anyone that has a history of birth control use, oral contraceptive use, should be on a little extra zinc too. I'll usually do like between 15 and 30 milligrams before bed. And then I do a lot of customized herbal tinctures in my practice too. Almost every patient is put on herbal tinctures. I like that because I can customize and get them into like one therapeutic prescription rather than having them take 20,000 capsules. And then I can address whatever's going on with them individually, whether they have mild anxiety or digestive problems or autoimmune disease. You know, I can choose the herbs specific for them. And then, of course, hormone balance. A lot of herbs are great for balancing hormones. So some of my favorite combos, I obviously can't talk about them all here, but there's a great traditional Chinese medicine formulation for PCOS, or polycystic ovarian syndrome, which is about 10 to 15% of cases of infertility. You'll see women that have what we call oligomenorrhea, where they go a long time between cycles. So they might have cycles anywhere from 30 to 120 days, or it might shift where they'll have 2 normal periods and then they'll go six weeks without one. Also commonly having trouble keeping their weight down. They can have more acne, especially around the jawline, due to higher levels of testosterone. Hirsutism, which is kind of a male pattern hair growth. So those are all signs of PCOS, and trouble balancing blood sugar. Now I see a lot of women who have trouble getting pregnant who don't have those classic signs and symptoms, but you might pick it up on blood work or just noticing that their cycles are irregular like that. So the combination of white peony and licorice are particularly good at rebalancing the way the hypothalamus communicates, helping to get their hormonal pattern to be more normal. And glycyrrhiza, or licorice, is also great at regulating blood sugar, which is a big challenge for women with PCOS. Another one a lot of people haven't really heard of is shatavari. Has anyone learned about shatavari? Shatavari is like one of my very favorite herbs. So it's asparagus racemosa is the Latin name, which I did not italicize, which is not correct there. But it's an Ayurvedic herb, so it comes from the Indian tradition. And in Ayurveda, they say it's for the woman with 1,000 husbands, which I just love. I think it's so beautiful. We should all take it. So it's like an Ayurvedic aphrodisiac and a reproductive tonic. I really see this be hugely supportive of healthy cervical mucus. So if a woman doesn't see that she's getting that fertile mucus, I'll usually put her on shatavari. And I will usually give it as a powder. You can get it as a root powder, and it's easy. You mix it into milk. Like the traditional way to take it is you do like a teaspoon at night, mixed into some kind of warm milk, whether it's cow milk or hemp milk. And you stir it up and drink it with like honey, almost like a chai. Ashwagandha was also traditionally dosed that way. If anyone uses ashwagandha. So I use shatavari quite a bit. And then another one that I use a lot is Vitex, which is like your classic women's health herb. It really helps to balance hormones. People think of it as helping the second half of the cycle, which is called the luteal phase, but it's really helpful in the first half of the cycle too. And so Vitex is most commonly associated with like low progesterone. That's when you want to give Vitex. People used to think that it actually was like a phytoprogesterone, but we know it's not now. But what it does is it helps improve communication between the brain and ovaries, and helps with proper what's called granulosa cell development, which granulosa cells are the cells in your ovaries that will then become the corpus luteum, which is the progesterone secreting cell. So you want to give it throughout the cycle because it helps those cells develop properly so that they make enough progesterone in the second half. Does that make sense? Kind of a confusing concept, but I think a lot of times, I know when I was trained in school, it was like if you have low progesterone, you always treat the second half of the cycle. And I've realized since leaving school that that's not true. You need to treat the first half of the cycle. The second half is when progesterone's made, but the whole setup for that happens in the first half of the cycle. Vitex can also decrease prolactin when it's elevated. So prolactin is a hormone that is pro-lactation, right? It's what makes women make milk after birth. But in cases of PCOS, a lot of times women will have prolactin that's too high, and that can help bring it down with Vitex. Some other favorites of mine are false unicorn root, which also can help with mucus production, and it's a kind of a tonic herb for the reproductive tract. Ziziphus, which is a Chinese jujube, and it's very cooling and relaxing of an herb, and it's a great sedative. So it's great for insomnia or anxiety, and it's one that's safer to use for women who are trying to conceive than something like valerian. Hemidesmus indicus, I've had a really hard time finding this in the U.S. This is another Ayurvedic herb that has amazing ability to decrease. It's like a great anti-inflammatory, especially in cases of autoimmunity. It can really help to decrease antibody levels. So I use it a lot for immune thyroiditis. I use it a lot for fertility when either partner has a history of an autoimmune condition, or you can actually have a type of infertility where the woman will have an immune reaction to her partner's semen, or the man can actually have an immune reaction to his own semen, interestingly. So it's an autoimmune condition, or alloimmune in response to the partner, but this can help to bring that down. And then I almost always have adrenal supportive herbs in there too, to help with stress management and just kind of overall hormone balance and communication. So some of my favorites, Rehmannia, licorice or glycyrrhiza, and rhodiola are really great when you have someone that's pretty pooped out. But what I see more and more now is people who I would say are stressed and wired, especially in the Northeast. It's very type A, very go, go, go. My husband and I, my family is out here with me on this trip, and when we first moved out to Seattle from Boston, we were just in shock because on the highway, the speed limits are 55 and everyone's going 53. And we were like, what's wrong with these people? When Boston, the speed limit's 55, you slow down to 82, right? So we both had such a hard time adjusting, but back in that environment, it's so fast paced. So pretty much everyone I see needs those calming sedative herbs. So I love withenia, which is ashwagandha. I also love holy basil. You guys use a lot of holy basil? Holy basil is what I take every day. I totally love it. It helps you grow roots and stay very grounded. Reishi mushroom is another one that people don't always think about as an adaptogenic herb, like a stress herb. They think of it more for immune support, but it's a powerful stress support herb. That's another one that I really love, and it's great to take that through the winter because it does help promote immune function too. So I'll leave you guys here with, and I'm happy, I can, if you want to give your email to Sarah in the back, I'd be happy to email this to you so you can have a list of the references. So, I do have the book, the Lunar Cycle book by Francesca up here. And some of the other things that people had asked about, like the website for charging and stuff like that. All right, so you guys have a couple minutes for questions.
Just wondering, are there any medications that you need to consider for interactions with those herbs? Like if someone was on a certain medication?
Not with the ones I talked about.
Okay.
Yeah, those are pretty safe.
What have you noticed with women that have been taking oral contraceptives for years and kind of their impact and kind of your thoughts on
I
that?
think it totally depends on the individual. I see, like I have, anecdotal stories of like my friends who, they're like, oh, I'm gonna get married, I'll go up the hill, we'll have a baby in like 6 months, and they get pregnant on the first time. I think that it happens very frequently that women will jump right back into their normal cycle, but I also see that women will have trouble either getting back into a normal rhythm or getting pregnant. So what I'll typically do in that case, and I recommend this now for any who's going off, and I'll do like a 1-month liver support program. But rather than being just like milk thistle or typical liver support, I'll also focus on different nutrients that support hormone breakdown. So like indole, 3-carbinol, sulforylane, which are from like broccoli. So things that like inositol is another really great nutrient for that. So things that will help with hormone balance from the liver.
That are also liver. Okay.
Yeah.
Cool. Thank you.
Can you comment on cost comparison for someone who comes to see you, say they come for 4 months, everything goes well, they have a healthy pregnancy, versus doing more the conventional route, say IVF or something?
Yeah,
Can you
so
just comment on that?
from a visit perspective, the visit fees, which we take insurance in the future, but for someone who paid out of pocket, they are looking at about $500 in visit fees over the course of the 4-month period, which is we charge $300 for the initial, and then I'll do like a 30 to 160-minute follow-up, and they'll live about $100 an hour after that. And then the second visit kind of depends, but generally they're spending $100 to $200 a month with both partners throughout the course of those 4 months. So an IVF cycle costs about $10,000.
Yeah.
So it is an investment to work with a naturopathic doctor. Labs are always billed to insurance, but it's 10% to 20% of what you pay for an IVF.
Okay, yeah, that's really cool.
Thank you.
Thank you so much. Thank you.
Thank you.